So for the next presentation of the day, we have Niklas Westerholm from PledPharma, the CEO of the company, here to present the company and provide an update. So without further ado, I'll leave the floor to you, Niklas.
Thank you very much, Richard, and a pleasure being here, I must say. As Richard mentioned, for those who haven't had the privilege to meet before, I'm Niklas Westerholm, and I'm the CEO of PledPharma. What I will cover today is really an update on our 2 late-stage development assets, both first-in-class. It's Aladote for the prevention of acute liver injury caused by paracetamol poisoning. There we have illustrated the development pathway going forward, subsequent to regulatory interactions we held towards the back end of 2019. We see 1 pivotal study going forward for market authorization, and this is pending on study-specific details that will be validated with the FDA and EMA during the summer. We also have PledOx for the prevention of chemo-induced peripheral neuropathy. There we have the global phase 3 program called POLAR that we are actually wrapping up, and I'll touch base a bit more on that now going forward. But without further ado, I'll go into a summary of the year to date. We have had a very, very hectic year, but also with some turbulence, to be very transparent. We started off the year, as I mentioned, with communicating that we saw a development pathway forward subsequent to regulatory interactions with the EMA and FDA, which consists of 1 pivotal study for Aladote for marketing authorization in both US and EU. However, we faced some major setbacks for our development asset PledOx, where we first communicated on the 23rd of January that the US FDA issued a clinical hold on PledOx. This was related to a few number of CNS-related adverse events. Here, the company still maintains its position that these few events, CNS-related events, are not related to PledOx and is also supported by the independent Data Safety Monitoring Board as well as other external experts. However, subsequent to that, we got the same challenge from the French authorities, ANSM, which we communicated on the 1st of March, where we then decided as a company to stop further dosing of patients in this pivotal program, POLAR. Furthermore, which we communicated on the 6th of April, was that we took a decision after a recommendation from the independent DSMB to close down the POLAR program with a data cutoff targeted for the 3rd quarter this year. This was driven by related concerns from the independent DSMB related to a few number of allergic hypersensitivity reactions that has been seen during treatment. So that's a summary of the year so far, which has been very, very turbulent. But moving further on, how do we see then the company today and what is our focus going forward? So I mentioned Aladote, which is a very, very important asset for us, and it also addresses a very important unmet medical need to prevent liver injury caused by paracetamol overdose. Here we have an orphan drug designation in the US. We are also eligible for an orphan drug designation in EU now after Brexit, and that's something we're going to further pursue. The focus here will be on the forthcoming regulatory interactions, on study-specific details on the upcoming pivotal study that we are planning to initiate. I think it's important to recognize that the concerns we have had around PledOx with regards to the hypersensitivity reactions, very important here to recognize that these reactions reported haven't been seen until after cycle 6 or after 6 cycles of dosing of calmangafodipir. Here it's worthwhile recognizing that Aladote is given once, it's a single dose administration, and hence we see the pathway forward there. For the POLAR program, as I mentioned, we are focusing on collecting data now, and that we will have a readout for subsequent to the data cutoff in the 3rd quarter of this year. It's going to be a robust data set we are collecting from these 2 phase 3 studies. we need to recognize that initial ambition of the Polar program was to recruit 700 patients in total. When we communicated the decision to close down the Polar program, we actually had recruited 590 patients, which then subsequently to a robust data set that will enable an efficacy and safety evaluation that will determine the path forward for PledOx. Furthermore, we are in a good position when it comes to financing. We have a robust cash position where we reported 221 million approximately Swedish kronor towards in quarter one. And we have calibrated before that what this will help us do is with the plans we have in place today, that will take us forward to at least the end of 2021. So to delve in more into the Aladote project, and as I mentioned, the ambition with Aladote is to become the new standard of care for so-called increased risk patients in combination or on top of acetylcysteine or NAC. NAC is an approved drug for this condition today, which caters for the majority of the patient population. It's an effective drug for that patient population. However, the patient population with increased risks are the 25% of the patients that arrive so-called late to the hospital after overdose. And late in this setting is defined as after 8 hours of overdose. So again, the ambition here with Aladote is to be added on top of acetylcysteine or NAC as a standard of care going forward. And as I mentioned before, this is a huge unmet medical need with a fairly limited patient population. So here we are eligible for orphan drug designation in Europe that we will further pursue. And we already have been granted orphan drug designation in the US by the FDA. To calibrate the incidence levels in paracetamol overdose, it varies very much between countries. The incidence levels are much more prevalent in the Nordic countries and the UK, but also in the US. As you can see on the screen here, we see the number of hospital visits from 2018, which of course is substantial. And please recognize then that 50% of these hospital visits leads to hospitalization. Out of these 50%, as I mentioned before, 25% of those are so-called high-risk patients or patients that are arriving late into the emergency room, which then NAC is not catered for to 100% or is not fully affected. If you also consider, so what does this mean then? So of course, it's very severe. Then when you arrive to the hospital and you have the risk of having acute liver injury, of course, if not treated effectively, this could lead to liver transplantation and also in some cases death. And that's of course what we try to prevent with Aladote. If you calibrate that to the burden on society, it's very astonishing numbers, and these are from the US, and they are old numbers, but from 2010. And we see that the cost for the society to treat these patients are over $1 billion per annum. And also, that's one important factor, but also, of course, it occupies beds in the emergency room. And as you can see on the slide, that the average patients with paracetamol overdose occupy a bed in roughly 3 days, slightly lower in Europe, but these are US numbers. If you then to move to, so where are we with Aladote and where do we stand? So back end of 2018 and early 2019, we published some very exciting results, I must say, from the first human clinical trial with Aladote. It was a so-called phase 1b, phase 2a study, where we tested Aladote on top of NAC, but also looked at NAC alone in 24 patients. The primary endpoint of this trial was, of course, safety and tolerability, which was met. However, since we studied these in patients, we also had the opportunity to look at signals of efficacy. And what we saw there was that the result indicates that Aladote may reduce liver injury based on some predefined secondary outcomes, such as ALT, which is gold standard used in clinical practice for definition of liver injury, but also other biomarkers such as K18, microRNA, etc. This is with Aladote together with NAC versus NAC alone. These results also generated some scientific interest and medical interest, I would say. So the results was published in Lancet in the eBiomedicine during the summer last year, but also it was called out as one of the highlights during the annual liver meeting in 2019 in Vienna in April by the conference organizers as a very exciting result. So that provides then the reason to believe to actually drive Aladote forward further. So we look into the future then. As I mentioned, we are on the pathway of a tentative study design where we're going to land some or discuss some study-specific details with the FDA and EMA during the summer. Here we're looking at one pivotal trial. It's actually a phase 2/phase 3 trial where we have a dose selecting element and a futility analysis as part of this trial. This is, of course, for maximization of efficacy and, of course, reduce or optimize the time to market, both from a time perspective, but also from a cost perspective. Here we're looking at the so-called increased paracetamol overdose patients, so the so-called late arrivals that are requiring treatment with NAC. We're going to have 3 treatment arms here. We're going to give NAC together with Aladote high dose, NAC together with Aladote low dose, and then placebo on top of NAC. We will also look into an interim analysis that will be futile, a futility analysis, which will have a dose selection component as part of it. We are negotiating the sample size with the regulatory authorities, and hence why we're not able to disclose that today. And also from an efficacy standpoint, the key endpoints here are, of course, ALT, which is, again, gold standard for diagnosis of liver injury, INR, but also some further aspects, which is very important, which is length of hospital stay. That is a very, very important parameter for us to consider when it comes to pricing and healthcare economic data. The planned study is expected to run in Europe and US as well going forward. So when it comes to study timelines then, to summarize this, we see that we have made very good progress during 2018, but also 2019, with the study results published, with the design, the tentative design of the pivotal trial, with landing the development program with regulatory agencies, with the achievement of orphan drug designation as well. And as I said, moving forward then, we are pending regulatory interactions for study-specific design details during the summer this year, and subsequent to that, planning to start the pivotal trial. This, of course, the start of the pivotal trial, as I'm sure you might have heard already today a few times, is very much pending on COVID-19 as well, and the ability to start the same. Based on those timelines, then we see regulatory submission and results towards end of 2022 or early 2023, with subsequent submissions and launch. If you want to calibrate the commercial opportunity here I'll give you some guidance. I tend not to give peak year sales graphs or curves, because the only thing with that is that it's wrong. It's all about the assumptions. So with this, I would like to try to give you some assumptions and flavor of the commercial opportunity. So based on the number you've seen before with regards to incidence levels, you see that you have 135,000 patients that are hospitalized due to this in EU5 and US per annum. Based on our market research, which has been a dialogue with the payers, but also prescribers, we see a pricing assumption around $5,000 per patient in the US. And also then you see a cost of goods here in very low single digit as percentage. So a very attractive commercial opportunity and MPV behind this. If I then switch gear and move to the Polar program for PledOx. We have had a lot of communication during the spring around PledOx due to the setbacks we have had. However, I think it's important to take a step back and look at how does the pathway forward look like, but also what data are we able to generate in quarters 3. So the Polar program consists of 2 double-blind randomized placebo-controlled studies, one in the adjuvant setting and one in the metastatic setting. These 2 studies were initiated towards the back end of 2018. Polar A and 280 patients was fully recruited in December 2019. Polar M, with the ambition of 420 patients, has not been fully recruited. And as I mentioned, we stopped the program due to the concerns around allergic hypersensitivity reactions, which was communicated on the 6th of April. The important piece here to take away is that the total phase 3 data that we are generating and we will have available post the data cutoff in Q3 will enable us for an evaluation of the safety and efficacy parameters in a robust setting. That will, of course, then determine the pathway forward for PledOx. As I mentioned, why can I say robust? The ambition was to randomize in this program in total 700 patients. When we closed down the program or stopped recruited in the program and dosing in the program, we had recruited already 590 patients. Where we have saw that 420 out of those 580 has completed more than 6 cycles of treatment, both with chemotherapy but also study drug. And there we expect that these have substantial treatment effect of PledOx despite dosing being stopped prematurely. As I mentioned, the data cutoff by the 3rd quarter is selected, so we are doing follow-up visits now. That as many of these patients that have completed 6 cycles, i.e. the 420 patients, also have completed their 9-month visit and collecting data. The 9-month visit is very, very important because that's where the definition of an evaluation of the primary endpoint is. So with that, I will actually stop, and hopefully we'll have ample time, Richard, for at least some Q&A, and thank you.
Thank you very much, Niklas. So if we can dig just a bit deeper into the setback and challenges for PledOx here. So starting off, can you explain the role of the drug monitoring and safety board and what data they had access to and what data the FDA had access to, and sort of start there?
Sure. And I'll go back to this slide, maybe talking about this. So I think when it comes to the independent, it's important to say, independent data safety monitoring board that consists of experts in the field of, for our case, neurology, oncology, and statistics. So they are independent to the company and they are privy to unblind the data throughout the study. So they have looked at data already since the beginning of the study, of course, and following the safety of the patients. That is the role, to look at the safety of the patients. They didn't have the same concerns, coming back to a question around the FDA. The FDA had concerns around a few number of CNS-related events. The DSMB didn't have the same concern as the FDA had. The FDA, for these cases, had unblinded data, of course, in order to make their judgment. So that's a difference between the two bodies. If you go further into, so why did the DSMB stop or recommend? They don't have the mandate to stop, but recommend to stop the POLAR program. That was driven solely by allergic hypersensitivity reactions, where they see that there is a perceived risk of oxaliplatin together with PledOx versus placebo. And of course, I am not privy to unblinded data myself, but one can imagine that since there were 8 cases in total of having these hypersensitivity allergic reactions, there is an imbalance between PledOx arm and the oxaliplatin arm only, or the placebo arm.
And do you have data on how common these types of allergic reactions are on standalone treatment with oxaliplatin?
Yes, of course. And I think this is very important to recognize. We were talking about 590 patients here. We have 8 events that I was referring to. With regards to treatment of oxaliplatin alone, it's actually 1 to 2% of all patients are suffering from any kind of allergic reaction. Again, so it's within that range, I would say, when it comes to the POLAR study. However, what one can imagine, or at least perceive, is that it's an imbalance again between the placebo arm and the active arm. I think it's also worthwhile mentioning that all these 8 events I'm referring to were resolved, and the patients are healthy, etc. So it was solved with the standard treatment versus allergic reactions as well.
Excellent. And could you just also perhaps clarify a bit on how you think this is obviously speculative, but how you think it might impact the road forward, the regulatory path forward, because this might have raised some skepticism with the regulatory authorities, and perhaps how you are working to add clarification to the process and the situation at hand.
So I think it's 2 sides to that. One, of course, we are working very eagerly with immunologists to try to understand what is its potential cause effect with Pledox together with oxaliplatin, and also why does it happen after repeated dosing. So we don't see it in the initial treatment, it's after repeated dosing. That's one thing. Then, of course, we need to wait before any further regulatory interactions. We need to wait until we have the unblinded polar data and read out of that, because at the end of the day, it all comes back to the benefit versus the risk of a drug. And of course, the perception of the risk here, we need to be very transparent, has of course increased due to these concerns. However, it's also in relationship to benefit, and hence why the data at hand, hopefully later this year, is so important for us, because that will determine the pathway forward. And as I mentioned, it's phase 3 data, and it's robust data set we are generating.
And just a final question to add some perspective to the situation. Could you give a recap of the historical events in terms of CNS and allergic reactions in previous trials with the compound?
And I think here we have published, of course, the results from the Pliant trial, and then there we have seen only 1 allergic event, allergic hypersensitivity event, and we haven't seen any CNS-related events at all. So this is, of course, the challenge for us as well, that when we look at the data from previous trials and history, we don't see this.
Okay, so Q3 will be important in terms of clarifying the final
Very important
data. Excellent. So in the essence of time, we'll have to cut the Q&A short here, but thank you so much for coming, Niklas. We look forward to following the regulatory and the clinical path for PledPharma going forward. So
thank you very much. Thank you.
Thank you.